Aesthetics by definition is elective. Dry eye disease is not. And when you put those two side by side, you blur the line between want and need. It creates a subtle shift. Doctors start to think, hey, maybe this is an optional service. Patients start to think, maybe my symptoms and signs aren't as serious. And once that idea takes root, dry eye stops being treated like glaucoma or macular degeneration, or it makes it much harder to make that link in both the doctor and the patient's mind, which are chronic sight-threatening diseases, and they start being treated like a luxury. And that's what concerns me. If we treat it as optional, we won't manage it with the consistency or seriousness that real medicine demands. Hello and welcome to the Chris Roll Podcast on iCode Media. Today I want to talk about what happens when medicine meets marketing. So please enjoy this monologue. As always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. The most common questions I get include, what ophthalmological codes or evaluation and management codes should I use? What ICD-10 codes do I need to bill with this CPT code? What CPT codes can be billed together and what can't? And my favorite, how do I manage a patient who has diabetes who comes in for a quote-unquote routine eye exam? These questions really highlight the confusion and uncertainty that serves as a daunting hurdle for providers, makes it more challenging for them to care for their patients and provide those patients with the best opportunity for a lifetime of ocular health and clear vision. That's why we built iCode Education for this specific purpose. Our mission is to provide optometrists with resources to help you understand disease states, revenue cycles, and billing and coding so that you can put that on autopilot and truly care for your patients. Check out iCodeEducation.com. That's EYECODE education.com. We've developed a premier billing and coding bundle that includes all of our billing and coding resources in one place. We also have a 10% discount code just for listeners of this podcast. Enter the coupon code EYECODEMEDIA22 at checkout. We'd love to work with you. Check out iCodeEducation.com. Hello, dedicated optometrists. Are you looking for a way to support your patient's vision and overall eye health? Let me introduce you to Vision Edge Pro, a visual performance supplement that stands out in our profession. Vision Edge Pro contains a balanced blend of mesozeaxanthine, lutein, and zeaxanthine in a 10-10-2 ratio. This combination has been scientifically shown to increase macular pigment density, which enhances visual performance, including contrast sensitivity and vision in glare situations. Additionally, Vision Edge Pro provides 300 milligrams of DHA and EPA, fulfilling the daily requirements for omega-3s as recognized by the leading health organizations. This ensures your patients receive the essential nutrients their eyes need for optimal health. Whether it's for everyday screen use, night driving, or enjoying the outdoors, Vision Edge Pro supports your patients in seeing their best. Recommend Vision Edge Pro for your patients today and help them achieve clearer, healthier vision. Contact your local Macu Health representative for more details. Vision Edge Pro, because your patients deserve the best in eye health. Go to macuhealth.com and use the coupon code PODCAST2024 at checkout for special discounts. So somewhere along the way, dry eye and aesthetics became linked. And honestly, it's one of the strangest evolutions I've seen in eye care. When did treating a chronic inflammatory disease become something that sounds like a spa service? So today I want to unpack this connection, not just because it's confusing, but because it reveals something deeper about how we think as a profession. First, I started noticing this crossover when companies were introducing IPLs, specifically IPL devices, which were historically used in dermatology, began entering into the dry eye space. And suddenly, the same device used to treat rosacea and tighten facial skin was being marketed as a cure for meibomian gland dysfunction, and rightfully so. It was studied. It became FDA approved in terms of a device, and on the surface, it sounds promising. Light-based treatments to reduce inflammation, improve gland function, rejuvenate tissue, and it works. But the way it was packaged and sold side by side with cosmetic claims really started to change the narrative. It turned medicine, i.e., taking a patient who can benefit from their ocular surface for meibomian gland dysfunction that fit well into what optometry does, into marketing. Hey, let's offer a service, an aesthetic service, where you don't necessarily know a ton about aesthetics. Not that optometry shouldn't do it. That's not the point of this. But it led to confusion, and that's why it matters. Aesthetics, by definition, is elective. Dry eye disease is not. And when you put those two side by side, you blur the line between want and need. It creates a subtle shift. Doctors start to think, hey, maybe this is an optional service. Patients start to think, maybe my symptoms and signs aren't as serious. And once that idea takes root, dry eye stops being treated like glaucoma or macular degeneration, or it makes it much harder to make that link in both the doctor and the patient's mind, which are chronic sight-threatening diseases, and they start being treated like a luxury. And that's what concerns me. If we treat it as optional, we won't manage it with the consistency or seriousness that real medicine demands. Now, to be fair, I'm not calling aesthetics not real medicine. It's not what I'm doing. But there is a legitimate and physiologic overlap between dry eye and aesthetics. And so when we talk about IPL, radiofrequency, or low-level light therapy, these devices all act on the eyelids, the glands, the surrounding skin. The meibomian glands sit right next to the tissue that dermatologists have targeted for years. So yes, a patient getting IPL for rosacea might incidentally notice improved gland function. And that's the origin story of how that crossover started. But the science doesn't justify equating the two. And so I want to unpack that data and what the data actually says. So let's look at intense pulse light therapy first. It's the best studied of the group. And, I'm just going to summarize a few, but a 2022 meta-analysis in eye and contact lens reviewed 15 randomized controlled trials, including over 1,100 participants. And it found that IPL, especially when combined with meibomian gland expression, significantly improved tear film breakup time, OSDI scores, and gland secretion quality compared to sham treatments or meibomian gland expression alone. A 2024 JAMA ophthalmology overview and then the Cochrane review in 2020 came to similar conclusions. IPL works, but the quality of the evidence is moderate, and there are some small sample sizes and short follow-up and inconsistent protocols that do lead to limitations, but even the American Academy of Ophthalmology's report labels the evidence as grade 2 or grade 3 and requesting improvements in larger studies, larger trials that are prospective and randomized or more of them to be completely definitive. But the bottom line is IPL, it works. The evidence shows that it works, and it has real biological effect and repeatable clinical outcomes. And it's a component in a layered dry eye strategy, not a standalone cure. So if we go to the next treatment option, we think about low-level light therapy. In low-level light therapy, or photobiomodulation, which is obviously newer in eye care, there was a 2023 randomized comparative study in cornea that found that both low-level light therapy and IPL improved signs and symptoms of meibomian gland dysfunction, with the addition of low-level light therapy providing a slightly better symptom release and increased tear meniscus height. Other prospective studies combining IPL and low-level light therapy in recalcitrant cases show some sustained improvements as well at months 3 and month 6, including drops in inflammatory markers like interleukin-6 and MMP9. And this is really the key, large-scale randomized controlled trials are still missing within low-level light therapy, and we don't really know the ideal treatment frequency, how often do we do it, what's the dosing, what's the long-term outcomes. That's still needed, and we should really demand that. And then radiofrequency. Radiofrequency is even newer in terms of ocular use. Mechanistically, it makes sense. We deliver thermal energy. We can liquefy meibum. It softens the gland, but the data is mostly level 3 evidence, expert opinions, and small clinical series. And, a 2023 perspective study combining RF with IPL and meibomian gland expression showed additional improvement in gland scores. but the symptom improvement wasn't statistically significant to IPL alone. And so there's really not a ton of high quality randomized trials yet that have compared RF head to head with IPL or low level light therapy. So we can say IPL is evidence supported, low level light therapy is promising, and RF is still emerging. And so these combination therapies do show some synergy, but the evidence is preliminary. And CooperVision and the AOA have joined forces in a groundbreaking initiative to transform how optometrists treat children with myopia. The Myopia Collective aims to unite our profession and its allies to challenge the status quo and elevate the standard of care for children with myopia. Everyone is invited to become a member of the collective. By joining, you pledge to act in slowing childhood myopia progression. Membership includes regular updates and information about the collective's efforts, access to educational opportunities and resources, and insights from the ambassador optometrists who advocate for community policy and changes supporting the collective's mission. Click the link in the show notes to join the collective today. If you're ready to stop feeling overwhelmed and start running a safer, more profitable practice, here's the next step. First, book a strategy call with us, Practice Performance Partners. We'll uncover the biggest risks and opportunities in your practice. Then, choose the package that fits your goals. From there, we'll get you launched with confidence, with clear systems, with expert support, and with peace of mind, knowing your practice is protected and set up to grow. Don't wait until something goes wrong. Book your strategy call with us, Practice Performance Partners, today. And I think we need to remember that. I mean, what all of that does, the reason I go through all of that is I get people that ask me all the time, hey, I got a new device that combines RF with low-level light therapy and IPL. And then I say, great, when do you want to use those devices in your practice? And so then the doctors, will kind of, in a perfect scenario, they'll know exactly which one they're going to use for which type of patient. But most of the time, all treatment algorithms are leading to that large cash pay package. And I think that's a challenge, right? It leaves patients who can't afford it or don't want to expend the energy or the money on those types of treatments with minimal other options from that doctor in their practice. And I think that's a challenge for our profession, and I think it's a challenge for patients. So, if I come back to TFOS DUES 3, right, when we look at management and therapy report, it now lists these device-based inter-office treatments for meibomian gland dysfunction, but it emphasizes the individualized care and cautions that the evidence base is still developing. So I think about the takeaway. So what's the takeaway about all of that? It's if you're offering these treatments, do it because the science supports it and you know exactly where it sits, not because the marketing supports it. And I think the difference between those two motivations is subtle, but it defines whether you're running a clinic or a med spa. And again, this takes nothing away from med spas. It takes nothing away from optometrists who want to run a med spa. But the two can be confounding. So I want to talk about the economics behind this trend. I mean, I'm going to be honest, they play a huge role here, and they're all cash pay services. And, if you think about an IPL device alone, which costs maybe $70,000, and a radio frequency, if you add it to that device, maybe you're at $100,000. And so these packages might sell for $1,400 for a treatment series to maybe $2,400 for a treatment series. And when a company tells you that you can recoup your initial investment quickly, that temptation becomes real. And because optometrists have spent decades working under managed vision care, taking low reimbursements for exams, services, and trying to make it up through product sales, again, most of this is subconscious, this model feels familiar. It's the same psychology. If I can't charge what I'm worth for medical care, maybe I can make it up by selling something that's non-covered or minimally covered. And this is where it gets dangerous, in my opinion. Because when you build your financial health on sales rather than services, then you start redefining your professional worth. And, my colleague, you've heard him on the podcast. He's got his own podcast on this channel. Dr. Aaron Warner sums it up perfectly. I asked him about this. And, I'll let him comment on his own show, but he said, for some reason, we get burnt out on fundamentals, on the very things that patient expects from us. We stop finding satisfaction in doing them well and repeat it over time, and success becomes more about selling, not serving. And I think that's a really important observation. It's not an indictment, really. It's just a wake-up call. And I think about this internally in our practice all the time. If our sense of fulfillment comes from a sale rather than an outcome, then medicine has quietly turned into marketing. And so what's that cost? Really, like, what's the cost to the profession when this occurs? The cost of that shift. I think externally there's a problem. It can make the public question whether we're selling solutions or providing care. Internally, it does something even more damaging, and this is where I fear it changes how we see ourselves. We start believing our diagnostic and cognitive work isn't enough, that our value is tied to something shiny, something we can sell. And the result is in the numbers. If you look at 35%, okay, I want to take a little bit of time to kind of unpack this. On the lower level, in fact, I'll even say that I was just at doing a talk for about 150 people, and I asked the room, this happens every single time I ask this question, in your patient population over the age of 18, how many patients do you think have dry eye in your patient population over the age of 18? And, 2 or 3 people shout out 90%, 100%. Okay, great. Okay, so most of you think that it's, meibomian gland dysfunction and ocular surface disease is prevalent in almost all of your patients. But let's just assume that it's only 35%, right? So let's say 35% of adults over the age of 18 have meibomian gland dysfunction. Then at minimum, a third of your patients that you see should be scheduled for dedicated ocular surface evaluations if we just follow DUs 1, 2, and 3. But when you look at real world data, most practices are following up maybe 5% of those patients at best outside of the comprehensive exam. So where they're diving deep into tear film staining, symptoms, systemic evaluation of symptom scores. So it's not a patient problem, it's a doctor problem. It's what happens when we stop treating dry eye as a disease and start treating it as a side gig that maybe we'll go into if we can sell something else. And so I want to talk a little bit about what I see as responsible integration. Again, this is not an indictment. It's just I'm trying to get you to be conscious of sort of a subconscious pull and draw, but what responsible integration might look like. So to be clear, I'm not saying you should never offer aesthetics. That's not what I'm saying at all, although I'm sure some people will take that from this. It's not. What I am saying is that you should earn the right to offer it by first taking disease management seriously. In a comprehensive practice, we should do that. Now, again, if you are running a side complete med spa, that's a different story. But if you're packaging that into your comprehensive practice, boy, you better be really good at glaucoma, macular degeneration, dry eye, allergies, et cetera, binocular vision, in my opinion, before you really try to undertake it, mostly because you're setting yourself up for potential problems. So before you buy a device, don't ask yourself, how many dry eye patients am I actively managing today? Do I have a defined diagnostic criteria and treatment protocol set up? Do I measure objective change like tear breakup time, staining, gland imaging before and after intervention? And if not, adding aesthetics won't fix the problem. It'll just hide it. Once you're consistently identifying and treating dry eye, maybe you say 35% of your comprehensive patients have follow-up plans that are outside of their comprehensive exam, then explore expanding into aesthetics. But do it intentionally. Know exactly where your IPL and your RF and your low-level light therapy fits within your protocol. Think about DUs 2 and when DUs 3, and when DUs 3 actually shows you that you want to pair treatments with the underlying type of dry eye, what are you actually treating with each one of them? Which specific layer of the tear film are you addressing? That's important. And that's how you're going to know what you're treating, and you'll know how you'll measure it, and you'll know what success looks like. So don't buy the machine first and then build the philosophy later. That's a real challenge, and that we see all the time in practice performance partners, and when people come to us with issues, they've purchased a device and it's sitting in the corner. So here's where I'll land. When medicine becomes marketing, clarity disappears. The lines blur between elective and essential, and between profit and purpose. And dry eye is not cosmetic. It's chronic. It's impactful. It's deserving of the same attention as glaucoma and macular degeneration. It doesn't mean we can't offer cash pay options, but when we trivialize it as optional, we lose credibility. But more importantly, we lose opportunity to truly change our patients' lives in measurable and lasting ways. And so here's my challenge to you. Audit your practice. Track your intervention rates. Recommit to evidence-based management first and devices second. Because when we lead with medicine, everything else, reputation, revenue, patient outcomes, will flow naturally from that. And that's one of the things that we see within Comprehensive Optometry Simplified. It's to give doctors a structured way to diagnose, treat, manage chronic ocular diseases with purpose and precision. Because one of these things, dry eye management, is a medical necessity, and the other, aesthetics, is optional. And when we confuse them, we don't just blur the message, we blur the mission. So I hope this was helpful. This is not an indictment of any one person or business. I just wanted to get this off my mind because I've been seeing a lot of advertisements for pairing the two. And I think it's important to consider them individually and independently. So as always, be sure to subscribe to this podcast, and I will see you next week.